and the organizers and the scientific committee for inviting me to come and give this talk. As you can see, the title of my talk is different what you see in the program, and part of it is because my friend Yusuf Yalma is not feeling that well, so I'm going to cover his talk as well. So the plan is to give you one talk. It'll be a long talk, but I'll cover the area of what's now called MAFLD. I've been in this field for 30 years, working in the field of MAFLD, and what I will do is to share with you what's the new nomenclature and why it actually changed over time. I'll give some data on the silent epidemic of MAFLD, and then really talk about how MAFLD is a part of the metabolic diseases, a little bit about the pathogenesis, what drives the progression of this disease, and really the role of underreporting of alcohol use in a large part of the world. I'll tell you what we use now to risk stratify these patients, and finally tell you about treatment, what treatments are available now, what will come actually in the future. So this is sort of the story of this disease. It was first, the term NASH, or non-alcoholic steatohepatitis, was first coined by a pathologist from Mayo Clinic, Jordan Ludwig. And he basically described a biopsy, liver biopsy, of patients who were not drinking alcohol, but they had damage to the liver cell that was very consistent with steatohepatitis or alcoholic steatohepatitis. So he termed this disease as non-alcoholic steatohepatitis. In mid-1990s, I was at the Cleveland Clinic as a staff, and we really developed this new term, non-alcoholic fatty liver disease. And we described it as a spectrum that included NASH as well as just fat alone. And I'll tell you why that is important. It is important because NASH is a progressive type of fatty liver disease, not non-NASH MAFLD or NAFLD. In 2002, I was at the AASLD single topic conference in Atlanta, and we tried to change the name at the time to make it more connected to its metabolic root, and of course that did not go through. But in 2020, a group primarily led by Jacob George from Australia coined this term MAFLD. The problem with this definition was that it combined alcohol and non-alcohol, so it was regardless of the amount of alcohol you used, and then got rid of the terminology or endpoint of NASH. Well, that was important because clinical trials of this disease included resolution of NASH as an endpoint. So some of us, including myself, we had the two papers in hepatology and Journal of Hepatology raising some question about this. And then in 2023, an international consensus group got together for almost a year through Delphi process, changed the name to MAFLD. Now, originally, NAFLD, as I mentioned, had NAFL, or this is basically fat in the liver without evidence of liver cell injury. This is the majority of patients with NAFLD, okay? The majority of patients with NAFLD, just remember that. This is a syndrome, it's not a liver disease. It's important to remember that because it's the NASH subtype that is progressive. And this is basically the type of liver disease that we need to talk about. Now, the terminology here with NAFLD, the fact was that, first of all, it was a negative term. It was basically defining what it was not, non-alcoholic. Two, it did not have any connectivity to its underlying disease, which was metabolic. And third, there were a lot of patient advocates in the meeting suggesting that the fatty term is stigmatizing. So MAFLD was defined as a part of a spectrum of steatotic liver disease. Steatotic liver disease means fatty liver, right? But it required having at least one cardiometabolic risk in addition to fat. And based on alcohol consumption, it was basically divided into three groups. MASLD, or metabolic dysfunction-associated steatotic liver disease, is a mouthful, less than 20 grams of alcohol in female and 30 in male. Then they have alcohol-associated liver disease. This is when you actually drink more than 50 grams of alcohol or 5 drinks per day in female and 60 gram or 6 drinks per day in male. That's the two extremes. They coined a new term called MAFLD. These are the patients that have a cardiometabolic risk at least, and then drink somewhere between these two groups. I'll tell you, these are boxes. These are boxes. So MAFLD was replaced by MASLD, and alcoholic liver disease was replaced by alcohol-associated liver disease, and the new category was created. So the question that was raised at the time, and I raised a lot of these questions, was that is MASLD really the same disease as NAFLD? And I think it was important because we had spent about 30 years of studying this disease, and if it was not the same, then we had to start all over again. And the second question that was raised was that, is really fatty liver or fat, is that stigmatizing? Because, you know, fatty liver is an English term. Not everybody uses fatty liver in China. They use different terms, so this is an English term. So the first question that we actually addressed and was published in Hepatology in 2022 is to look at other name, MAFLD. Concordance between the two, that we used actually a pretty large data set, was pretty good. However, when you look at predictors of mortality in NAFLD, that was actually having insulin resistance, was an independent predictor of mortality in NAFLD. In MAFLD, it was alcohol, because alcohol was not limited. When we looked at the second definition of NAFLD versus MASLD, on perfect concordance in terms of the diagnosis with kappas of 0.968. I've never seen this high kappa, but predictors of mortality were the same. These are basically hypertension, diabetes, and metabolic diseases. So they are basically the same disease. Now, looking at what's associated with long-term outcome, so when you look at the data set from tertiary care center, this is a database that I have, about 6,500 patients, and when you look at the concordance, it's pretty high. 99% of patients who have NAFLD now actually could be qualified as MASLD, 99%. But when you look at the enhanced data set, which is population-based database, you see that 5% of patients who had NAFLD initially no longer meet the criteria of MASLD. These are usually younger people, and these are usually those who do not have overt evidence of a metabolic abnormality. They may have insulin resistance, but it wasn't actually measured. All-cause mortality was also the same once you controlled for confounders, especially the cardiometabolic risks. So at this point, we think that NAFLD and MASLD are basically the same in terms of at least clinical implication. The second question was, is NAFLD or fatty liver itself really stigmatizing? This is a survey, a global survey of both patients and providers that we carried out from 68-item patient questionnaire and 41-item provider survey, 2 different surveys. Almost 2,000 patients were enrolled here from 21 countries and about almost 900 physicians. The bottom line is that from a patient perspective, about 8% thought fatty liver was stigmatizing. They thought obesity was stigmatizing. That was 25%. But when you look at provider sort of data, 40% of providers thought that fatty liver was stigmatizing. So it's more of a perception of the providers that fatty liver is stigmatizing than patients, but there is a group of patients that will have fatty liver as stigmatizing. When you have stigma, whether it's from fatty liver or obesity, quality of life is actually impaired. So stigma exists mostly in providers' perspective than patients. There is really no perfect term at this point, but we think that there is a great deal of overlap, and in 2025, we have all chosen MAFLD as the term to use. And of course, we probably will refine this over in the future. So for all of you, I think it's better to use the term MAFLD than MAFLD or even NAFLD. And I'm actually saying this because I was resistant to change of this name. NAFLD was created by my team, but I think at this point it's important to actually have a consensus. Now let's look at epidemiology of MAFLD. This is from a meta-analysis that I performed and we published a few years ago. The global prevalence of MAFLD is 30%. But if you look at the bar graph on the bottom, and if you look at most recent data in the meta-analysis, the prevalence is 38%. 38%. The prevalence is high in certain regions of the world, specifically in the MENA region, Middle East and North Africa, and also in Latin America. Up to 40% are affected. The subtype that I mentioned to you that is the really liver disease, the NASH, now it's called MASH, the prevalence in general population is about 5 to 7%. Now that's of course lower than MAFLD, but remember the prevalence of hepatitis C that caused all the problems for us in the past 3 decades was in the United States was less than 2%, probably less than 1.5%. So this is quite a bit larger in terms of its prevalence. Problem is that the prevalence is also quite high in kids. This is from a very recent publication in hepatology suggesting that the prevalence of MAFLD in kids is about 10%. And if you actually get into younger sort of adults and then adolescents, the prevalence goes up to 15 to 20%. Of course, the reason I'm here is that the prevalence is extremely high among those with type 2 diabetes. This is another meta-analysis that we performed, and the prevalence, global prevalence was 65%. But if you look at the most recent studies, the prevalence of MAFLD among type 2 diabetics is almost 70%. 70%. I'll get into this a little bit later. This is a cartoon of the natural history of this disease. Most patients with MAFLD don't progress. Those who have MASH can progress, and the progression rate initially is slow. There are some that would progress faster, but also there is a regression, spontaneous regression, that probably is related to changes in lifestyle, whether it's actually weight loss or less drinking and all of that, that actually can affect this. Once you develop more advanced liver disease, especially well-established cirrhosis, regression is very, very difficult, and we are finding this out in clinical trials. Again, sort of a cartoon and simplified version of pathogenesis of this disease. This is a multi-hit disease, meaning that you can go through this multiple different ways to get to the end point of having liver cell damage with fat. So probably the most important organ is white adipose tissue that produces the inflammatory adipokines and cytokines, and that leads to basically damage of liver cells and activation of stellate cells. Those are the collagen-producing cells that leads to fibrosis and then ultimately cirrhosis. But there's also dysbiosis, an imbalance of a microbiome that can lead to this, and oxidative stress. All of these can actually have at least some role in the progression and development of this disease. I'm not going to get into this. We can get into some of these issues when we talk about drugs. What is going on around the world about this disease? This is from Global Burden of Disease, publication we had a couple of years ago. You know GBD is basically going to look at regions, and there are multiple regions that are listed on the first column. And we're looking at liver cancer death and cirrhosis death from 4 different liver diseases: MAFLD, ALD, hepatitis C, and hepatitis B. And as you can see, especially in the liver cancer death group, you see those boxes that are red. Those are annual percentage change in liver cancer death, mortality, and they're all red, meaning they're going in the wrong direction. Look at the far extreme right column. That is mortality from cirrhosis secondary to hepatitis B. And you see a lot of green. That means that whatever we are doing with hepatitis B, probably because of vaccination, we are actually making a great deal of stride there, and there is an improvement of liver mortality from hepatitis B cirrhosis. Now, this region, of course, Turkey is not always technically considered part of the MENA region. It's part of Europe, it's part of Asia, it's part of everywhere. But I'm going to just show you the data that we have actually recently published, looking at a meta-analysis of PubMed, just looking specifically at Turkey. The prevalence in general population of MAFLD in Turkey is about 40%, and when you look at type 2 diabetics, it's about 75%. 75%. When you look at the annual percentage change, this is from another study that we have done, to see how it's actually happening in different countries in terms of changes over time, you see that Turkey has an increase year by year of about 1.038% every year. So it's an area of growth, unfortunately, for Turkey. And this is related not only to the prevalence, but outcomes, whether you're looking at mortality, liver cancer mortality, cirrhosis mortality, or even DALYs, which is disability-associated liver years. They're all actually increasing in this region. Again, Turkey has one of the highest increases in both the annual percentage change, the change every year, both in terms of compensated cirrhosis and decompensated cirrhosis. Liver transplantation, of course, is a treatment for end-stage liver disease. We published this about a month and a half ago, looking at database of all transplants done in the United States, as well as Europe, 30 countries in Europe. So you get liver transplantation for advanced cirrhosis, that's a non-HCC, and you can see that the number one indication for liver transplantation, both in the United States and Europe, is alcohol, followed by MAFLD. When you look at those individuals that get transplanted because of liver cancer, in the United States, the number one indication is MAFLD, followed by hepatitis C. In Europe, that's ALD, followed by hepatitis C. So in the United States, actually MAFLD has become the number one indication for liver transplantation for HCC patients, patients with liver cancer. Economic burden. This was published actually a couple of weeks ago in Clinical Gastroenterology and Hepatology. We did modeling to estimate the economic and clinical burden of MAFLD in 9 different countries. This includes Japan, Saudi Arabia, US, UK, France, Italy, Germany, Spain, and Brazil. It's an extremely complicated model. You do Markov model, you estimate transition rates, prevalence rates. So it took us over a year to actually do this model. But the bottom line is that when you look at clinical cases of MASH, it's increasing in all of these 9 countries. And when you look at the direct healthcare cost associated with this disease, this is only liver-related cost. This is not including diabetes and obesity and cardiac sort of complications. It's significant, and by 2040, it doubles or triples in certain regions of the world. So this is important from policy perspective to get a handle on this disease. Generally speaking, people think that this disease is asymptomatic. I really don't believe it's asymptomatic. 40% of these patients have fatigue, but they're used to fatigue. They think that that's part of aging or part of other chronic comorbidities that they have. But when you look at these patients' quality of life, especially if they have fatigue, their quality of life is impaired. This is a study we published a few years ago, looking at multiple quality of life questionnaires, and they're impaired, especially in the presence of fatigue among patients with MAFLD. One group of patients that you need to pay attention to, it's the so-called lean MAFLD. It probably is a misnomer. It's probably those are individuals that have normal BMI, because a lot of this was actually done by BMI. The global registry suggested, this is a registry that we actually run, and there's lots of Turkish patients in this registry from Yusuf Yalmaz's team. The prevalence in the registry was about 6.8%, And when you look at different part of the world, in the United States, about 5%, but areas of the world where there is high prevalence of quote-unquote lean MASLD is South Korea and some part of Asia, and the prevalence is about 25%. In my view, those patients do have, all of them will have insulin resistance and will have central adiposity. The outcomes is actually not benign. These patients can develop adverse outcome and increased mortality. What the problem is in the United States, as you can see over this almost 25 years, you see that the prevalence of MASLD is increasing. This is all MASLD patients. When you look at the prevalence of lean MASLD, it's decreasing, meaning that most MAFLD patients in the United States now are obese. So it's a story of obesity in the United States. In the Asian population, where this disease actually is not that uncommon, you'll have lower mortality due to CVD. Remember in the mortality slide that the #1 cause of death among MASLD is cardiovascular. In this case, it's liver. And again, there is, despite the fact that these folks have lower BMI, and as you heard from Ralph, they probably also have sarcopenia, that they have increased visceral adiposity. And they also have a genetic biomarker, a variant, PNPLA3, that also predisposes these patients to more progressive disease. Let me just put this in the context of metabolic milieu. So when you look at MASLD, it's part of all the other metabolic diseases, the cardiovascular disease, chronic kidney disease, cancer. These are extrahepatic cancers, sarcopenia. And I'll get through some of these. These are some of the data that's been sort of generated. I would say that the percentage that will have type 2 diabetes is probably closer to 30%. 15 or so percent will have CVD, about 20% will have CKD, but more advanced patients will have more CKD. The vast majority of patients I mentioned do not have MASH, they have the MASL without a D, it's just fatty liver. Now in terms of cardiac, there is a spectrum of cardiac diseases that are important here, but the three that I actually circled here are probably more established: the heart failure, coronary artery disease, and atrial fibrillation. The exact mechanism of this is not entirely known. It probably has to do with thickness of epicardium, as well as infiltration of fat in the myocardial tissue itself, and that may explain the atrial fibrillation. When you look at the cohort from Sweden, and they were followed for quite a while, you can see that compared to the population norm, there was an increase in terms of MACE, but also there was increase in terms of CV, cardiovascular death in these patients. In fact, when you have on the right side of, on my right, you see that the more advanced the liver disease in terms of stage, the higher the cardiovascular mortality. And I sort of put this together that if you develop more advanced liver disease, you probably have more severe or more profound metabolic milieu, and that may explain both of these. Extrahepatic malignancies, and this is from a paper that will come out early next year. I'm the editor of this issue of the Clinics in Liver Disease, and Yusuf Yalmaz, actually this is his paper. So there is a lot of different mechanism of how MASLD can be associated with extrahepatic malignancies, especially colorectal cancer, gastric cancer, pancreatic cancer. This is a study from the Mayo Clinic that patients were followed for a while, and you can see that the risk of course, liver cancer is high, but stomach, uterus, and pancreas, as well as stomach, was higher in women and men. In fact, when you run multivariate analysis and included obesity in that model, MAFLD was independently associated with these cancers. Sarcopenia, there is, of course, obese sarcopenic patients. This is a study we published using an Haynes data set. This is an important complication of this disease. And when you look at these patients using DIXA using that for defining sarcopenia, and activity level was actually determined using a standard self-report. You'll see that sarcopenia is associated with inactivity, but sarcopenia was also associated with increased mortality. And in fact, compared to patients with MAFLD without sarcopenia, those MAFLD patients that had sarcopenia had increased all-cause mortality and cause-specific mortality. So having sarcopenia in the context of fatty liver disease is bad. Now, of course, you know that as you develop more advanced liver disease, you develop sarcopenia. That's a different type of sarcopenia. They're both associated with increase in mortality. What are some of the drivers of this disease? This is a very busy slide, and I'm not going to go through everything. It's a complex disease, meaning that there is genetic and there is environment sort of role that is actually driving this disease. I'll focus a little bit on the issue of alcohol, some genetics, and maybe some of the socioeconomic issues. And maybe, of course, we already know that type 2 diabetes and obesity are important. You can divide these two into two types of predictors. Those that are fixed, cannot do much about it, gender, age, and genetics. On the other hand, there are some that are modifiable, and we've been talking about the modifiable risks here in the past couple of days. Let's look at one modifiable risk, alcohol. The biggest problem we have with this disease is that alcohol consumption is underreported, both in the clinic as well as in the population-based studies. So when you look at population-based studies, this is from the United States, and this is actually one of the probably 10 different studies, you see that the prevalence of alcohol-associated liver disease is quite low. It's about 1.25%. Well, the problem is that if you come to my clinic, half of my patients have alcoholic cirrhosis or alcohol-associated cirrhosis. So there is a discrepancy in terms of the number of patients that I see in the population reports and then what I see in my clinics. There is a way to actually correct for this in the population-based studies, and we corrected that. And actually, as you can see, the prevalence of ALD and met-ALD doubled. So that was studied from population side. This is actually another one that comes from Alexander Krok from Denmark. He's very interested in this sort of area. He looked at about 2,900, almost 3,000 patients from a general population sort of clinic that came in and divided them up based on risks, either to alcohol group or metabolic group. And about 1,400 patients, 1,433 patients, met the criteria of MASLD. He actually did a blood test that's a biomarker for alcohol consumption in the past few weeks. It's called PET testing. It's really phosphatidylethanol testing in the whole blood. So you need whole blood for this. Look at the MASLD group. And also he had a questionnaire called Audit C, and you can see that the red part of the bars are those that actually are going to be outside the criteria for MASLD. So about 39% of patients that had MASLD were drinking more than the criterion. So remember, there is the underreporting, and some of these patients would be using alcohol and just not tell you, unintentionally or intentionally, but that's the reality of what we are dealing with. The other, of course, issue is that drinking alcohol or metabolic sort of dysfunction in general is not static. It doesn't remain the same. So if you look at one point in time, you may get one piece of information. But if you actually look over time, things may change. This is another study from Alexander Krok's team. They basically looked at patients over a year with different categories. So there were patients who did not have steatotic liver disease at the top. There's MASLD in the yellow. You have met-ALD in green, and then you have ALD. So they did PET testing at the beginning and then also after a year. What's interesting is that 25% of patients who did not meet criteria for steatotic liver disease after a year, they did. They moved to one of the categories. 38% of those patients that had MASLD became either met-ALD or ALD, and 60% or 62% of met-ALD or ALD patients became another category, making the point that this is not a static condition, this is a dynamic situation. And what was mostly the important driver of this was, number one, alcohol consumption changes, and number two, it was actually metabolic abnormality reflected as how much fat you had in the liver. Why is that important? Well, it's important because there are two things with alcohol. Alcohol can cause liver damage directly. We all know that. But the second important issue is that alcohol can also worsen metabolic profile. As you all know, alcohol can actually cause obesity or worsen obesity, cause hypertension and dyslipidemia, and the two could be a double whammy that can actually make the metabolic milieu or damage even worse. Some evidence for this is from a study from Scandinavia, looking at male patients that the highest tertile of waist to hip ratio, and when they drank 1 drink a day, that was equivalent to 4 drinks if you're in the lowest quartile, meaning that even 1 drink actually could be much more damaging if you have visceral obesity. This is from another study of NHANES that we published, 4,000, almost 300 patients. The bottom line of this is, when you look at mortality, if you have excessive alcohol use in the context of the diagnosis of metabolic syndrome, the risk of mortality was the highest. It's highest. So when you have patients that come in with alcohol consumption and they have metabolic abnormality, that's the place to get really serious about both metabolic abnormality, sort of reversal or improvement, but also alcohol. So putting it all together, we're going to present this data next week at the big liver meeting, so I'm going to show it to you first. 41,000 patients for 30 years from all the studies of NHANES that we have collected, and we adjusted alcohol consumption, well, self-report here from the studies that we have. There are 2 points. One, if you look at the change of MASLD, met-ALD, or ALD over 30 years, they're all increasing, almost doubled, all of these. If you don't control for alcohol, the rate of ALD and met-ALD is half of what's actually reported. Pure MASLD without any alcohol is extremely rare. It's probably about 5%. Remember, 40% versus 5%. 5% will have no alcohol history. Pure alcohol is very rare. It's 0.01% in the general population because 96% of patients with ALD have at least one cardiometabolic risk in the United States, 96%. So who are those patients that have pure ALD? These are younger patients that happen to have alcoholic hepatitis, and they have pretty bad outcome if they don't get transplanted. So this is a different type of disease that we're talking about. In terms of mortality, alcohol had the top mortality, followed by met-ALD, and followed by MASLD. So MASLD, of course, mortality is higher, premature mortality is higher than the general population, but it's actually lower than met-ALD and ALD. In the first graph, you see that presence of metabolic abnormality, especially diabetes and hypertension, are independent risks for MASLD premature mortality. But when you look at met-ALD or ALD, it's binge drinking, not just drinking, binge drinking, defined as having more than 5 drinks at a time in the past 12 months. That's how it's defined. And when you combine these risks, because people don't come in with just one risk, so if you have hypertension and diabetes together, you have the highest risk of premature mortality in the MASLD group. But if you have type 2 diabetes and you binge drink, then the risk is highest for patients with met-ALD and ALD. So met-ALD and ALD or alcohol-associated liver disease, when you have diabetes and you binge drink, that's actually a bad combination. This actually may explain what's called the paradox of alcohol harm, because there's sometimes the same amount of alcohol, if you look at different sort of part of the socioeconomic stratum of the society, those who actually may be drinking a little bit less, but they're on the lower strata, they have high mortality. Well, the reason is that they have other risks that are environmental that probably also produces this adverse event. Genetics. This was from something we paper published in Nature Reviews a few years ago. PNPLA3 is probably the most important genetic variant that would predispose patients for having not only MASLD, but also progressive disease. The second study is basically a study of our database of almost 2,300 patients that had SNPs for 4 different SNPs, PNPLA3, MBOT, TM6, SF2, and HSD17B13. These are the SNPs that have been associated with this disease. The bottom line is that PNPLA3, if you want to remember, one SNP or genetic predisposition sort of test that will predispose these patients is actually PNPLA3. It is not commercially used at the moment, but at some point in the future, it will be. When you combine PNPLA3 plus diabetes, those were both actually, the risk was even higher. Now let me turn into a different area of risk, which is the social determinants of health and food insecurity. This came from, again, from Enhanced data set for young population. 10% of adolescents had MASLD, and about 10% were considered food insecure. When you look at the prevalence of MASLD, it was higher in those who were food insecure, especially in Hispanic girls, young girls. So again, food insecurity also drives this disease. An ecological study from NVSS we published also last year looking at what's called food swamps and food deserts. Food swamps means basically that you have food, but it is actually bad food. A lot of ultra-processed food, a lot of food that is, from junk food that you have. And food desert is that where you don't really have food. And there's actually plenty of areas of the United States. When you look at food swamps and food deserts, they're associated with high rate of MASLD. And in fact, they're associated with higher mortality in MASLD. And finally, bringing this to a global sort of study, this is a study from the Global Burden of Disease, and we combine this with United Nations Food and Agriculture sort of data. And food environment metrics were things like cost of healthy diet and affordable of healthy diet, undernourishment, et cetera. The bottom line is that if you look at the red bars, these are countries that are considered high socioeconomic countries. They're actually having sort of unhealthy food environment leads to a higher rate of MASLD and outcomes. When you look at poor countries, it's the opposite. And the reason there is that malnutrition or actually hunger is actually driving some of the outcomes versus the high socioeconomic countries. The point here is that when you look at this from a global perspective, this is not always the same disease across the world, and you need to make sure that you understand the environment you're dealing with to study this disease. So now that you know that there is a group of patients with MASLD that can progress, how do we find them? Well, I've shown you this slide before in terms of the high prevalence in the type 2 diabetics. The other issue is that not only there is high prevalence of MASLD in type 2 diabetics, almost more than 60%, almost 70% of these patients have MASH, 40% have significant fibrosis, and 15% have advanced fibrosis. This is pre-cirrhosis and cirrhosis. And the more component of metabolic abnormality that you have, the higher rate, the higher prevalence of MASLD. Well, more importantly is that this is from 2 studies we have published that, again, from population-based data with mortality data, that when you look at independent predictors of mortality from a clinical standpoint, diabetes actually is the most important predictor of mortality. The next actually graph shows you that the more component of metabolic syndrome you have, the higher the risk of mortality. That was the first part of the risk stratification. The group that you want to find, we now know that. They should be diabetics or at least individuals that have at least 2 cardiometabolic risks. The second point of this is that when you look at meta-analysis, and we published the first paper in 2012 showing that when you have on the biopsy stage 2 or higher, that was an independent predictor of mortality. So combining these two, you can now identify patients. But nobody wants to do a liver biopsy these days. Hepatologists don't want to do liver biopsy. They all send them to radiologists. So how do we do this without a liver biopsy? Well, we're using non-invasive tests. And some of these are blood-based tests that you know, the AST, the ALT. They are very poor because you can have patients with significant liver damage due to NASH or MASH, but they have normal liver enzymes. So the newer tests are listed in the middle. This is FIB4, alpha enhanced liver fibrosis test, PRO-C3. I'm not going to get into this, and then also the radiologic tests. FIB4 basically uses laboratory tests that are readily available. And you don't have to remember the formula because you can get it in the internet and you just plug in and see what the number is. Remember the number 1.3, because that's actually the most important number for this disease in terms of risk stratification. Another way to risk stratify is to look at stiffness, liver stiffness, as a surrogate of fibrosis. And this is measured by either ultrasound technologies or MR technologies. They're both very good, but I think MRE or MR elastography is more accurate, but less accessible and more expensive. And the only blood test that's available and approved in the United States is called Enhanced Liver Fibrosis Test. It's being made by Siemens, and they're actually now available in a lot of sort of central laboratories. These tests don't only actually measure stage of fibrosis, they also are predictors of outcome. This is a study from FIB4. Not going to get into detail. I can tell you that FIB4 predicts outcome. VCTE, which is transient elastography, predicts outcome. ELF testing, this is a study we published a few years ago, predicts outcome, and so is MRE. These tests are actually now great because they can also predict outcome. They are not just surrogate of fibrosis, they're surrogate of long-term outcome. This is a study we got published, actually it's in publication right now. You can see it in hepatology. We collected almost 18,000 patients from 41 different countries through our global council. They all had a liver biopsy. They had a lot of NITs. And the bottom line is that when you look at these three tests, the FIB4, transient elastography, and Agile-3 is basically transient elastography plus a few other tests like AST, ALT, age, and diabetes in Agile-3. Agile-3 performed the best in terms of predicting stage of fibrosis. When you look at predicting outcome, this is from a second paper that was just accepted in hepatology, you can see that NITs predict outcome as well. So in a global study, you show that these NITs are replacing liver biopsy. If you have NITs, that's all you need to do. So why are we doing all of this for NITs? Well, because they are now used in different algorithms. I'm going to show you the three most recent ones. EASL, which is the European Study for Liver Disease, and this is EZAD from diabetes, and ESO. They all came up with this algorithm. Remember at the top of the box, it shows basically who are at risk. These are basically patients with type 2 diabetes, obesity with at least one other cardiometabolic risk. And then they do FIB4 as a first-line test, FIB4. To ADA, basically the same thing, same risk. They also included pre-diabetics here and obese with additional cardiometabolic risk. And the difference between these two guidelines is that one uses one cutoff of 1.3, that's the ADA guideline, and then the other one uses two cutoff, 1.3 and 2.67. I actually think that's a little bit more complicated. So we did a global consensus guideline that was published last month in Gastroenterology, our premier journal. And again, we use just 1 point. If you happen to have type 2 diabetes or obesity with what other cardiometabolic risk, then you do a FIB4, and if FIB4 is more than 1.3, then you do a second line test. We do a second line test in general with elastography. And if transient elastography is more than 8, those are the patients that need to have additional assessment and get treated. The vast majority of patients, by the way, when you do this, will have FIB4 less than 1.3. What do you do with those patients? If they are diabetic or have other cardiometabolic risk, you repeat FIB4 every year. If they don't have any risks, you repeat them every 3 years. So you can just follow those patients. This is not general population screening. This is really technically case finding, right? So is this actually cost effective? We did a Markov model and showed that in the United States, implementing these guidelines was cost effective. We did another study in the United Kingdom and showed that in the United Kingdom, this risk stratification was cost effective. So it's cost effective to find these patients. So finally, you find your patients, and these patients are at risk, and you want to treat them. The most important message that I have is that from a hepatologist standpoint, you need to get out of this only treating liver disease and only fibrosis. We have to basically change our perspective to improve all these diseases, cardiac, kidney, of course, metabolic. This was usually CKM. I added the L because L is also important. And lifestyle is now the foundation. This is from our guideline in terms of weight reduction. If the patients happen to be obese or overweight, the recommendation is to lose 10% of body weight. This is based on a study from Cuba. It's actually the only study that's been published like this. And if you lose 10% of body weight, you improve fat, inflammation, and fibrosis. Of course, if you do bariatric surgery or if you do endoscopic bariatric procedures and you achieve the same thing, good things will happen also. What do you do if you have, quote unquote, normal body weight? In this context, there are two things. First, we still recommend weight reduction of about 3 to 5%. Hopefully that you can improve the visceral adiposity with exercise. Diet. There are different diets that have been looked at, but I think the Mediterranean diet has been talked about, but you can't really adopt Mediterranean diet in India or China, so you have to basically think about the component of what's in the Mediterranean diet and move that forward. The key to this is remove the ultra-processed food from your diet. That probably is the key and most important aspect of this. Exercise is important, and you saw this the other day. I'm not going to dwell on it. But it's important to remember that you need to both do cardiovascular sort of exercise, but also resistance. Because the resistance, the muscle, as you heard, is an important sort of an important organ in this context of insulin resistance. So, and also as we have sarcopenia in this disease, both nutrition in terms of protein intake and resistant muscle improvement is also important. And of course, avoiding alcohol, smoking, these are actually not only important from a perspective of general health, but in this liver disease, alcohol certainly plays a role, and there are some data that suggest that smoking may also be detrimental. There's some actually other data suggesting that caffeine intake may improve fibrosis, not only in MAFLD and others. It's a little bit controversial. I certainly drink a couple of cups of coffee a day for hoping to help with my fatty liver. This is the algorithm that I think is probably, at the moment, a very good algorithm by ADA. I was a member of the committee that developed this for the ADA guideline. And what they did was to combine sort of the stage of liver disease with sort of treatment of different products that can be used preferentially. So for obesity, you can see that if you're an early disease, like F0 and F1, then you have GLP-1s and dual agonists. And if you're F2 and F3, you basically have the same thing. When you get to more advanced patients, then of course you can't use these drugs, especially in those who have decompensated cirrhosis. For diabetes, of course, the drugs that we've been talking about, pioglitazone is really important to be considered because there is data for treatment of MASH, primarily from Ken Kuzi, who's trained by our friend Ralph, a big fan of pioglitazone, and Ken was the first author of this paper. So it's important to remember that pioglitazone is pretty cheap, and it can actually be used in patients with MASH that have type 2 diabetes. With more advanced patients, again, when you get to cirrhosis, although I know that insulin is not popular here, but I can tell you that in more advanced patients, that's the only thing that we can use. The only two drugs that are currently approved specifically for MASH, one is resmetirom, and the other one is, of course, semaglutide, and I'll cover those. Now, remember, those are approved for F2s and F3s. You cannot give it to patients who have early disease, and you cannot give it to patients who have cirrhosis. So let me just, this is a cartoon of all different sort of pathways and where the drugs hit. I'm going to just start with resmetirom, which is a THR-beta agonist. This study was pretty large, called MAESTRO program. Over 2,000 patients in this program. And the phase 3 trial that led to the approval of this drug in the United States, initially about a year and a half ago or so, and now a few months ago in Europe, it got approved first in Germany, but it's going to come in France and other area, was based on this study. That when you look at the two endpoints that FDA actually accepted for efficacy was resolution of NASH without worsening of fibrosis, and then one-stage improvement of fibrosis without worsening of steatohepatitis. And this drug met both of them. And when you look at non-invasive tests, there are actually some improvement of non-invasive tests. Some side effects, but they're generally speaking minor side effects. How do we use this drug? Now, we start the patients on F2 and F3 based on NIT, not on biopsy. Based on NIT, you can start these patients. Once you start, we do a blood test and about 4 weeks to make sure that there's no liver toxicity. 3 months, we do another fibroscan. 6 months, another fibroscan. 1 year is when we decide if the drug is working or not. If there is a 25% decrease in liver stiffness, we would consider that patient to respond. If those patients are not responding, then we have to actually go back and say, okay, what else can we do? And now we, of course, have a second drug that was approved a few months ago, and that's semaglutide. And this was based on this multi-center phase 3 clinical trial of ESSENCE. And as you can see here, the primary endpoints were the same, basically improvement of fibrosis by one stage without worsening of steatohepatitis or steatohepatitis resolution, and both of these two were met. I have to say that I'm not too impressed with fibrosis improvement, but it still is there. There is there, and I think that this fibrosis improvement will get better with time. This was only 1 year study. And when you look at the non-invasive test, and especially liver stiffness and ELF test, you see that there's significant improvement. Side effects, you know the side effects. They're all GI side effects with this drug. How to start this drug and how to monitor it has not been established yet. We actually have a guideline committee that will meet next week or in 2 weeks in Washington to update our global consensus to bring in actually semaglutide, resmetirom, and other drugs into this context. A few other groups of these drugs that I just want to remind you. This is another THR-beta agonist. Technically, it's stronger. It's made by a company called Viking. And as you can see at the top, not important to actually pay a lot of attention to the data, but just looking at these two endpoints, there is actually improvement of the same outcome. But this is, again, phase 2. This is tirzepatide, the dual agonist. Quite impressive data in terms of, again, the MASH resolution without worsening of fibrosis. Side effects are the same. But as you can see, there is an escalation of the dose so that people can tolerate it. This is survodutide from Boehringer Ingelheim. It's not for treatment of diabetes, obviously. It's for obesity that is being used. Again, dose escalation, phase 2 study. And again, there is significant improvement of both NASH and fibrosis. Similar side effect as other GLP-1 or dual agonists. There is another family of drugs that's been very exciting. These are the FGF21 analogs. And this one is a drug that was made by Boston Pharmaceutical for F2 and F3. And they have significant improvement after 24 weeks of treatment. This company was purchased this year by JSK. So you know that they are actually getting into this game. Another one of this type of drug, which is the pegozafermin. It's a FGF21 analog, and it's a longer sort of, as you can use it weekly. And again, there is significant non-invasive test improvement. And this company was called 89 Bio. Company was purchased by Roche Pharmaceutical in the past 6 weeks. Again, a lot of excitement here. There is the last one. This is once weekly. This is from Harvard study, effervescin, and this was by a company called Akero. Again, significant improvement of fibrosis, both by invasive liver biopsy as well as non-invasive testing. And side effects are primarily GI side effects. This company was acquired by Novo Nordisk in the past 2 weeks. So excitement is quite a bit. Now let's get back to the PPARs. This is the triple PPAR agonist, lanifibranor, and a phase 2 study has been published. Actually shows significant improvement of both steatohepatitis and resolution of and improvement of fibrosis. Company called Inventiva. We are the central site for liver pathology for this study, and it's going quite well, and I expect the data will be out next year. So this group of drugs would probably be in the market and will remain actually a part of our regimen. I believe this disease will need to basically be treated with multiple regimens, as we are doing that in diabetes. So it depends on where you are in terms of fibrosis. If you have more fibrosis, you may want to think about mechanism that will be more anti-fibrotic. If you have a more metabolic sort of side, you may want to look at those mechanisms that will be more anti-metabolic. Another sort of concept that some of us are promoting is sort of this idea of care pathways, integrated care pathways with so-called metabolic clinic, which I think is a real opportunity for us to come together. It's hard to do because it requires multidisciplinary teams to come together, either in one place. Columbia, for example, has done this, or virtually you can do this, and you can screen high-risk patients, and then you treat these patients' cardiometabolic risks in the same setting by different sort of providers. Cardiovascular risk needs to be assessed. We have to actually look at all other comorbidities that you already are doing, which is eye examination and your neuropathy and your kidney issues, but nobody is actually looking at the liver. That should become part of the screening of these patients. And then, of course, integrative weight loss centers should be a part of this, and pharmacotherapy of diabetes and prediabetes should be a core for all of this. And this is really sort of the interdisciplinary team that we're advocating. To deal with this disease, that's not enough. Drugs will not be enough. So you have to start with sort of patient-centric care where you have the drugs and the multidisciplinary sort of metabolic clinic, but then you need to get to social nutrition. There is significant push of sort of these ultra-processed food by industry, of alcohol by industry in the United States, especially focused on kids and young people, and we need to address this, very challenging. And of course, we need to have healthy, sort of living policies. And some countries have done this. I can tell you that Saudi Arabia, for example, has taken down as a part of the policy to improve activity issues in Saudi Arabia. So some of these policies need to happen. Unfortunately, in 2025, the World Health Organization has not recognized MAFLD as an important non-communicable disease, and it should be. And some of us are really pushing for this so that it becomes a part of the risk of this sort of metabolic sort of problems that we deal with. So my take-home messages is that MASH cirrhosis, and associated complications are increasing everywhere in the world, and specifically in Turkey. It's a part of MASH is a part of the dynamic spectrum of steatotic liver disease. I'm not suggesting we should change the name, but we should be aware of the fact that every time you see the patient, you need to assess alcohol accurately. In our practices, doing PET testing for alcohol is now routine, and also measuring their alcoholic status. And as I mentioned, they're part of the metabolic system. You have to actually assess their cardiovascular risk, their kidney risk, their sarcopenia risk. So those are some of the things that you can do. And those that are modifiable, you at least can do something about and help those patients. Clinical risks in NITs are used to risk stratify. Easy to do, especially in the primary care setting. If you have some of these tests, it's very easy to find out which of your patients, which probably will be less than 20% of your patients, will be at some risk that you need to identify, and this needs to be done. And of course, lifestyle is the first sort of line of treatment. If you happen to have the drugs available, use it. The ones that are available for treatment of diabetes will be, pioglitazone as well as semaglutide and others. But if they're actually MASH-targeted treatment, please use those. And I think in the future will be combination. And I actually think that because of the impact of this sort of environment into this, having a global policy, regional, national, and global policy to address this epidemic is going to be important. So I'm going to stop here, and thank you very much for the invitation and also for taking it. Thank you. Glad to take any questions before I fall.